Good evening. My name is Rabbi Daniel Lehmann, and I'm the president here at Hebrew College. It's my pleasure and privilege to welcome you here this evening for this first in a series of two communal conversations leading up to the November elections. This one, as you know, we'll be discussing the ballot 2 here in Massachusetts on death with dignity or physician-assisted suicide, depending on what side of the issue you're on. And on October 30th, 29th, I'm sorry, October 29th, Monday, October 29th, at Andover, Newton, our two schools will be hosting a discussion on Mormonism in American public life with two wonderful people who are experts. One, a professor of business at Harvard Business School, who's a leading Mormon lay leader, as well as an important business professor, and there will be a conversation with someone who did her PhD dissertation on the history of Mormonism in American life. So that's taking place there. And both of these programs leading up to the election are co-sponsored by Hebrew College and Andover Newton Theological School. And I want to just recognize the president of Andover Newton, Reverend Nick Carter. Welcome. We are neighbors and partners on many different levels here on this holy hill. And this is just one manifestation of the work that we do together. We do academic work together for our students, and we have interfaith leadership programs that we do throughout the year, and all kinds of projects that we're involved with together. And this is one of the elements of our work together that we're sharing with the public. So I just want to welcome you again, say how pleased we are that you're here to discuss this rather timely and important topic. I'm also pleased that my wife, Dr. Lisa Lehmann, is going to be moderating the discussion. She's really a wonderful community resource on issues like this as a medical ethicist, and she'll be introduced in a minute. But I think this is the first time that she's had an opportunity to participate and lead such a program here at Hebrew College. So I'm very, very pleased that she's here with us. And let me just take a moment to introduce Josh Langer, who's the Director of Special Projects here at Hebrew College. He's working with me on a variety of public fora that we're offering this year to engage different parts of the broader Boston community in the work that we do. And he'll be telling you a little bit more about that and upcoming events. But Josh is a wonderful addition to our staff. He started this year. He's also leading our Makor Middle School supplemental program and doing a great job at that. And he's actually a recent graduate here of Hebrew College with a master's degree. And without further ado, let me introduce Josh Langer.
Thanks, Rabbi Lehmann. It's so great to see all of you joining us tonight for having you participate in this important conversation. I just wanted to briefly mention a few upcoming opportunities that we have as part of this special projects portfolio. Rabbi Lehmann mentioned the second part of this conversation series on October 29th at Andover Newton. We hope you'll join us for that. And then a few weeks later, in the middle of November, we'll be starting a new monthly Beit Midrash series, an opportunity for the community to come together, study some really fascinating Jewish texts, make some new friends, and learn with some leading Jewish educators and professionals from the Boston area. So we're excited for this program series to start as well, and there'll be other ones along the way. You'll hear about it. You don't need to hear about it now. But without further ado, I want to introduce all of you to Dr. Lisa Lehmann. Let me get this bio, very impressive, I thought.
Lisa Lehmann is the director of the Center for Bioethics at Brigham and Women's Hospital.
associate professor of medicine and medical ethics at Harvard Medical School, and a practicing primary care physician at Brigham and Women's Hospital. She received her BA from Cornell University, where she studied philosophy and was a college scholar. She attended Johns Hopkins University School of Medicine and completed her training in internal medicine at Johns Hopkins Hospital. She received her PhD in philosophy from Johns Hopkins University and a Master's of Science in Clinical Epidemiology from the Harvard School of Public Health. She studied Talmud at Midrashet Lindenbaum and Drisha Institute, and in the spirit of full disclosure, as you heard from Rabbi Lehmann, she is married to President Lehmann. So we needed someone to be sandwiched between the rabbi and the doctor, and I took that opportunity. So without further ado, it's my pleasure to introduce Lisa.
Thank you, Josh, and thank you, Rabbi Lehmann. So it's a real honor for me to be able to be your moderator this evening in this conversation about the legislation that we all face as citizens of Massachusetts that we're going to be asked to vote on November 6th. And before I'm going to share with you an overview of the legislation, the petition, as well as some of the data that we have on this issue of assisted dying from the state of Oregon, where it was legalized in 1997. But before we do that, I just want to take a moment to introduce our panelists. After I present that overview, our first panelist will be Maria Teresa Davila, who is a Roman Catholic laywoman and assistant professor of Christian ethics at Andover Newton Theological School. Her main area of interest is understanding the intersection of Christian values and principles, such as the option for the poor, love of the neighbor, and charity with U.S. civil society. Through this lens, she examines issues such as immigration, consumerism, use of force, and class identity in Christian ethics. Maria Teresa will give us an overview of the Christian perspective on assisted dying, and then after that, we'll hear from Rabbi Terry Bard. Rabbi Bard is a Reform rabbi and clinical psychologist, ethicist, and researcher. Since 1976, he's been a member of the Department of Psychiatry at Harvard Medical School, and from 1984 to 2008, Rabbi Bard directed the Department of Pastoral Care and Education at Beth Israel Deaconess Medical Center. In 1996, after 30 years in the pulpit, Dr. Bard was named Rabbi Emeritus of Congregation Shalom in Chelmsford, Massachusetts. He is also a member of the Reform Task Force on Assisted Dying that was published in 2003, and from my conversation with him, he'll share with us the evolution of his thinking since that task force to today as we confront this issue in 2012. So, I'm going to begin with this is just a roadmap for the evening. We'll talk about the Massachusetts ballot question number 2, which the state attorney general has titled it "Prescribing Medication to End Life." And I think that's really interesting, first of all, to note that the state chose that language because that's very different than the proponents of the legislation. The people who crafted the legislation, actually very close colleagues, some of whom are very close colleagues of mine in the Division of Medical Ethics at Harvard Medical School, entitled it Death with Dignity, which was modeled after the legislation in Oregon that was passed in 1997. And that has a whole set of implications when we refer to it as death with dignity. And many people would say, implying that the only way in which we can have a dignified death is through the use of a lethal dose of medication to end our life. The opponents of this legislation prefer to call it physician-assisted suicide, and there's a stigma associated with suicide that they're attaching to this phrase. And I think a more neutral or descriptive way of referring to this issue is prescribing medication to end life, or some would say assisted dying. So I think the language that we use to frame this issue is actually very important, and it's just worth reflecting on that for a moment. I want to share with you then some of the data on assisted dying from Oregon, and just briefly go through the ethical arguments from a secular perspective, and then I'll turn it over to MT Maria Teresa for a discussion of the Christian perspective, and then Rabbi Dr. Bard will talk about the Jewish perspective. And then my hope is that we'll really have an engaging conversation about this issue that is so important to us as citizens of the state of Massachusetts. So first of all, what does actually this legislation say? Many people, we all received in the mail, actually, something from the state that outlines what this is about and the arguments, but we all lead very busy lives, so it's difficult to take the time to do that. So I thought I would just briefly review it. So the first question is, who is eligible for assisted dying under this legislation? It has to be people who are 18 years of age or older. You have to be a resident of the state of Massachusetts. You have to be capable of making and communicating a healthcare decision yourself. You have to have a terminal illness, and the way a terminal illness is defined is someone who has an expected prognosis of 6 months or less to live, and that is to be determined by 2 physicians. And then lastly, you have to be capable of self-administering the medication yourself. And we'll reflect in a moment on what that means in terms of who's not included in this legislation, and I think it's important to be aware of that also. Now, what's the process? If a patient or an individual is interested in embarking on this and obtaining a prescription to end their life, what is the process that they need to undergo? And the legislation lays this out very clearly. There has to be an oral and written request for the medication to the physician. There has to be a second oral request to the physician 15 days after the initial request. There also has to be a 15-day waiting period between the patient's initial oral request and writing the prescription. And there has to be a 48-hour period between the patient's signed written request for the medication and the physician actually writing the prescription. And then lastly, the patient has to sign a standard form. And if you look in that pamphlet that you received at home, there's actually the text of what that form looks like. And that form has to be witnessed by 2 different individuals, one of whom cannot be a blood relative or an heir to any estate or financial benefits that might ensue on the death of that individual. I think that's an important point. Actually, before you advance the slide, I just want to take a moment to reflect on the fact that there are a lot of steps here. It's not as easy as getting a prescription, for example, for a cold. You shouldn't be getting a prescription for most upper respiratory tract infections anyway, or let's say for a urinary tract infection. It's a fairly involved process, and that's intentional. It's intended to ensure that this is a voluntary request by the patient and that this is thought through, and that it's not an impulsive decision. Okay, John. What about the physician's responsibilities? So the physician has to assess that the patient has a prognosis of less than 6 months left to live, that they actually have decision-making capacity, so that the patients, for example, that have dementia or that are not clear in their thinking as a result of other medical illnesses, those individuals would not qualify. And it has to be a voluntary request. This cannot be something that the family wants, but the patient does not want. So the physician has to assess that. The physician also has to inform the patient about their diagnosis, their prognosis, the risks of the medication, what's going to happen when they take this medication, that it's going to end their life. What are the alternatives? That we have options in terms of palliative care, in terms of controlling pain and suffering and symptoms at the end of life. Patients have to be informed about those options, the option of hospice care, and they also have to know that they have the opportunity to rescind the request for this medication. Even once they make that oral request or that written request, they always have the opportunity to rescind it, and nobody forces them to take it even once they get the medication. They also have to refer the patient to a second physician to confirm the diagnosis and prognosis. In addition, if there's any question about the possibility of a mental illness or depression that may be impairing the patient's judgment, there's an obligation to refer the patient for a psychiatric or mental health evaluation. The physician is also supposed to recommend to the patient that they notify that the patient notify their family of their intention to obtain this lethal dose of medication and use it. It's important to recognize that that's not a requirement. So some patients may do this, some individuals may do this and never tell it their family or discuss it with their family. And physicians are also supposed to recommend that patients not take this medication alone. There have been some cases where it has failed, or patients vomit the medication, and also not to take the medication in a public space. They have to then document all of this in the medical record, and then they write a prescription for this lethal dose of medication, and they have to inform the pharmacy that they're doing it, because it's not a typical dose or a typical medication that would normally be prescribed. It's important to note that that's the point at which the physician's obligations stop. Physicians do not participate in, are not required to be present when the patient takes this medication, and are not, do not need to be there or do anything beyond writing the prescription. There are some reporting requirements to the Department of Public Health in the state of Massachusetts that will have yet to be worked out if this law is passed. Okay, so let's just reflect for a moment on who's excluded. Individuals who are expected to live more than 6 months are excluded. And I think it's important to note here that even people who have a chronic illness, if they're expected to live more than 6 months, so patients with Parkinson's disease, for example, patients with congestive heart failure that may not be at the advanced stages, patients with dementia who may have many years to live, do not qualify for obtaining a lethal dose of medication under this legislation. And no matter what their quality of life, it's not about quality of life per se. Individuals who lack decision-making capacity cannot participate in this, even if they requested it before they lost their decision-making capacity. So if a patient is at the early stages of dementia or early Alzheimer's, where they may have the capacity to say, I know that when I get to the point where my dementia is very advanced, I do not want to live like that, they will not be able to qualify for obtaining this kind of medication. Because when they obtain the medication in those last 6 months of life, they have to have full mental capacity. And individuals who cannot self-administer the medication, so someone who's a quadriplegic, they may be very dissatisfied with their quality of life, but they could not avail themselves of the opportunity here, what some people would call the opportunity, to obtain this medication. Patients with ALS or Lou Gehrig's disease who may lose the ability to swallow later in life, those individuals would not be able to participate in this because at late stages of the disease, when they could not swallow themselves. Okay, so I want to turn now to some data from Oregon, because this is, in many ways, a large part of the conversation and the controversy surrounding this issue. This is a slide that depicts the number of people who have obtained lethal prescriptions, prescriptions for lethal medication in blue. The blue bars are the number of people who have obtained prescriptions for lethal medication. And then the number of deaths due to taking this medication. And you'll note that there's a discrepancy here, and that it has gradually increased over time. Oregon passed its law in 1997, and we have data from 1998 through 2011. You can see that in total, 935 people during that time period requested lethal prescriptions, and 596, or about 64%, have actually died from taking a lethal medication under this law. What's interesting there, I think, is that there's a discrepancy between the number of people who are obtaining this prescription and the number of people who are actually using it. And that's a large part of the argument and the conversation here. That part of what's driving people in these circumstances is the desire to control the timing of their death. And just having that prescription and having that medication is sufficient for many people, and they don't necessarily need to act on it and take the medication. But the knowledge that they have that ability to end their life if they have so much suffering is part of what comforts them. There's been a lot of conversation about whether or not people who are most vulnerable in our society are going to be using this legislation, and will it lead to abuse? And that it may lead to people who are most vulnerable participating in it, and that will be a problematic thing for many people in our society. So I just want to share with you some of the socio-demographic information that we have from Oregon that tells you who's using this. So in Oregon, these are the racial characteristics. On your left, you see the race of patients who died using the Death with Dignity Act in Oregon, 98% of whom were white. On the right, you see the race of Oregon residents in general, where it's about 86% who are white. But in large part, it's white individuals who are engaging in this. And this shows you the education level. Again, on your left, you see those at the education level of the individuals from the state of Oregon, and 45% had a bachelor's degree or higher, 25% had some college degree. So highly educated individuals, and then on your right you see the general educational level of people from the state of Oregon. And what about the underlying illnesses? Who's engaging in this? What are the terminal illnesses that are driving people here? 81% of them had cancer. Okay, the remainder, about 8%, had ALS. That's Lou Gehrig's disease, or amyotrophic lateral sclerosis. So just to give you a sense, that's the primary driver is cancer. Okay, and then a few other things to note that I think are important in terms of the data that we have from Oregon and the Death with Dignity Act there. Only 6.7% were referred for a psychiatric evaluation. Many people would say that's shocking. We know that patients with a terminal illness, it's very common for them to have some depression, and that seems like a surprisingly low number. Interestingly, however, almost 90% were enrolled in hospice. And many people would argue that Oregon actually has the best palliative care, the best end-of-life care in the country. And in large part because of this legislation, actually, that the palliative care and the attention to death and dying and symptoms at the end of life significantly increased as a result of this legislation. And despite the fact that it's not required, 94% informed their family of their decision to participate. And you can see on the right that the location of death, about the majority of people died at home. And we know from other data in the medical literature that most people would much prefer to die at home as opposed to dying in an institution or in a hospital. Okay, so what about the end-of-life concerns? This just shows you what were the concerns that people who engaged with the Oregon Death with Dignity law had that drove them to obtain this prescription. And these concerns were documented by the physician who wrote the prescription, and you should note that they're not mutually exclusive categories, so that there could have been more than one concern expressed by the same patient. And you can see that the primary reason on your left is that they were concerned about losing autonomy. 90%, 91% of people who were requesting this prescription were concerned about losing autonomy. 88% were concerned that they were less able to engage in activities that made life enjoyable. 82% were concerned about a loss of dignity. About 54% were concerned about losing control of bodily functions. 36% were worried about them being a burden on their family or friends or caregivers. And 22% were concerned about pain or inadequate pain control. Okay, so I'm going to very quickly just go through some of the primary arguments in favor of legalizing assisted dying and some of the arguments opposed to it from a secular perspective. And then I just hope that will frame our thinking so that we can really delve into the religious perspectives on this issue, which is really the purpose tonight for us as people concerned with how religion approaches these issues. So the primary argument in favor of legalizing assisted dying is that it protects the autonomous choice of individuals. And what do we mean by that? When we talk about autonomy, we're talking about the right of individuals to make decisions for themselves. to determine what happens to their body. And the argument here is that individuals, not the government and not physicians, should decide how they wish to die. It's my choice, should be my choice as an individual to make that decision. In much the same way in medicine that we've gone from a very paternal, what I call a very paternalistic approach to decision making with patients, where we, as it used to be the case, that physicians would make decisions about what they thought was in the best interest of patients. Over the years, we've shifted from that paternalistic approach to one that has emphasized autonomy and patient involvement in decision making. And we have, over the past 30, 40 years, with some landmark Supreme Court cases in this country, beginning with Karen Ann Quinlan in 1976, where we had, the Supreme Court decided that we had the right to withdraw a ventilator on patients, to the Cruzan case in the 1990s, where the Supreme Court decided that surrogates or family members could make decisions on behalf of individuals that didn't have the capacity to withdraw treatment. We've had a series of decisions in this country that have given patients more autonomy and more decision making. And many people would argue that this is just a natural extension of those decisions and those processes. The other argument in favor of legalizing assisted dying is that the proposed law actually contains a lot of safeguards. The medication has to be self-administered, and there's a structure in place that ensures that patients actually remain the driving force and decision maker in this process. And then people also turn to this data that I've just shared with you from Oregon, and I think we need to be critical of that data. I've presented it to you, but I don't think, I think it's important to recognize what's also not there. But some people would argue that the data from Oregon addresses any concerns that we might have about abuse within this, with this process. So what are the arguments against assisted dying or against legalizing it? So some people would say, well, doctors are not prophets and we're not very good prognosticators, right? This law is dependent on the idea that a patient has a terminal illness defined as being able to live only 6 months or less. And we know that sometimes we say that a patient has 6 months to live, and that may not be the case, and they may live much longer than that. So that's a problem if we're thinking that someone only has 6 months to live and they don't. Other people would say that doctors should not be prescribing a lethal dose of medication because that's incompatible with our role as physicians and healers and our Hippocratic oath to do no harm. And actually in the Hippocratic oath, there's a very explicit statement about not prescribing lethal medication. And there's concern that it may erode our patients' trust, in general, societal trust in the profession of medicine. Many people would argue that the safeguards that exist within the law are not sufficient. For example, one of the witnesses to the request that has to be signed by the individual can be an heir who will benefit financially from the patient's death. No witness is required when the patient takes the medication. So we don't really know what's happening. We don't know if the patient is out of it and if the family member is actually coercing or forcing the medication. Some people have concerns about that. And since no psychiatric consult is actually required, patients with treatable depression may actually choose assisted dying instead of psychological care. So those are some of the concerns about the safeguards. I'd also put out there that there's an argument to be made about whether or not legalization of assisted dying will change our cultural norms surrounding dying, and whether or not there may be financial or emotional pressure on patients that may diminish the voluntariness of this decision. As this becomes normative, if it becomes normative, there may be very little concern about choosing this as an option, and how we die may radically change. Many people argue that this is a slippery slope, and actually if you directly ask the crafters of this legislation about the idea of whether or not from an ethical perspective we should legalize voluntary active euthanasia, and what I mean by that is the request from a patient to administer a lethal injection. So not assisted dying where the patient takes a dose of medication themselves, It self-administers it, but the request to actually have another person or physician administer a lethal medication, which is legal in some European countries, that many people would argue that this is just a stepping stone or there's a slippery slope towards voluntary active euthanasia, and that people would say that there's a slippery slope from voluntary active euthanasia to involuntary active euthanasia to people who are not requesting it. And the crafters of this legislation are actually pretty frank that from their perspective, ethically, they don't have a problem with that, but they know that politically it would not be feasible, that we would never get that to be able to be passed. So we're circumscribing our legislation to assisted dying. But there's also a desire, I think, to broaden this, these options to individuals who lack decision-making capacity or have a poor quality of life, or they have individuals who may be able to make decisions on their behalf when they don't have the capacity to do that for themselves. Okay, so I'm going to stop here. We're going to hold questions. You may have questions. It's a complicated law, but I want to make sure that we have a lot of time for our other panelists, and so I'm going to turn it over to MT for a conversation on the Christian perspectives.
Thank you, Lisa. I feel like I need a breather after that introduction. I don't know about you. I'm really shifting, not positions necessarily, that's probably the wrong word tonight. I'm shifting what we're talking about in the sense that I am not a bioethicist. I don't have a medical training. I am a social ethicist. So I view a lot of the medical technologies, end-of-life issues, reproductive concerns or reproductive ethics concerns within the scope of social ethics. And at that, trying to have the conversation, empowering and enabling people of faith to bring their positions of faith to these particular questions in the public square, a diverse public square at that. I do it from a Christian perspective. But we've held a number of conversations, especially at the level of the Interreligious Center for Public Life, between here and Andover Newton and other sponsoring bodies, where we have these conversations of bringing faith into the public square on major critical issues that affect policy and affect our political decision making. So that's some of what I would like to introduce to you today and invite you to consider within your own religious tradition what it is that you want to bring into this conversation, what it is that you want to bracket in bringing, in addressing this conversation, what it is that you wish your maybe greater religious bodies would be more vocal about publicly in these conversations and so on. And you'll see how that plays out as we're going along. So, I just want to start with this quote. It's from Christina Trina. She's a Catholic ethicist at Northwestern University, but she has studied bioethics extensively and has written on this topic. And she wrote in Religious Perspectives on Assisted Suicide, where she was also looking at a feminist perspective. The bindingness of law depends on its justice, and its justice is dependent on its genuinely advancing the common good. Key phrase here, common good. So again, looking at this very personal, very private, or maybe family-related question from a social, common good, greater public perspective, and whether or not a decision that we make publicly or politically, or legislation that we accept, contributes to the advancement of justice. Now, we can spend some time unpacking each one, and I'm going to make some questions later on about language and how do we even get a handle around the language that we use on this, such as common good, justice, etc. And as a follow-up part to this quote, the near religious consensus that does exist on the issue of physician-assisted dying or death with dignity is deceptive, even within those religious bodies in which conquered or autocratic authority is strong enough to generate opposition, such as my tradition, the Roman Catholic Church. There are conscientious people who dissent. and are vocal and write and advocate and whatnot. So there is lively, engaged conversation on all sides of a very broad ethical spectrum within any religious tradition. And so even within our own traditions and within our own churches, it becomes very difficult to have some very critical discussions that we wish maybe we could discuss in the open, but it's very hard to do sometimes. So since I approached this question from a social perspective, I want to balance a social view of the human person, really very broadly sketched, and an individual autonomous view of the person. So at least for a Christian vision of the person, we are part of a family, there's a social integration, a social dimension to the person. That's why I say particularly a nuclear family, but also broadly defined as larger society. We have a sense of intergenerational belonging, so that the human family is not just the one that is concurrent at your time of life, but also that which has come before, that which will come after. Bodily integrity is part of the common good, so it becomes your own personal bodily integrity, but it becomes under the protection or under the commons that a nation, a body politic, a society is supposed to protect. And so bodily integrity is a social concern. In an individual sense, we present a view of the person as free, endowed with freedom, with a personal relationship with God or the divine, that in fact endows a person with individual rights that must be protected from one person to the next, that bodily integrity is a personal matter, and that also affords a person to a sense of privacy, a sense of ownership, a sense of responsibility to their own medical decision making. Common to both visions, however, I think, at least in the Christian understanding of an ethic of medical care, is that both the social and the autonomous or individual perspective of the person is beloved by the divine creator God, human being and becoming, is understood within a framework of divine reality. So we do not see the person outside of an understanding of divine reality, part of a greater understanding of the created order. So it's not just the person as an atom or as an individual construct, but as part of the cosmos, the entirety of creation. However, each person is viewed as irreplaceable and unique, and created with reason, and therefore with autonomy, decision-making, free will. And then I put there natural law, which is, in Christian ethics, and especially Roman Catholic perspectives, natural law is used a lot on issues of bioethics with respect to reproductive technologies, abortion, end-of-life issues, and care, and life-sustaining technologies. I personally have a hard time utilizing natural law to address these. I feel like they restrict the social dimension a little bit, and that they don't permit us to have real conversations about the technologies that are being developed. And so I'm bracketing that, I'm putting it there because it's very central for a lot of, especially my own traditions, understanding of bioethics and biomedical issues. But for the discussion at the social and policy level, I'd rather not engage in that necessarily. So Roman Catholic understanding of human life, and not necessarily personhood. And again, this is another key term that is a difficult term to utilize and to define. The position of the Roman Catholic Church is a consistent ethic of life. So the dignity of the human being, or the human life, begins from conception to natural death. This has both personal and social dimensions. Politically, we advocate for the life of the unborn, and then policies and practices throughout a person's life in community that protect and nourish human dignity throughout life. Human dignity encompasses spiritual, material, and intellectual dimensions, or integral development. So just as an example, in terms of social policies, you won't see a Catholic advocating for an economic policy that strictly looks at an index, a growth index such as GDP, because it is a rather limited view of the development of a person. Rather, we want to see how is a society developing in terms of its intellectual, cultural capacity, the role of women, how children thrive in schools, etc. So that's this fuller view of the person that includes both material and spiritual and bodily intellectual dimensions. Okay, so spending a little bit more time on this part after my quick introduction of Christian anthropology for social ethics, social bioethics. What is it that we can bring to the public square then? What is it that we can contribute in a pluralist setting, religiously plural setting, that is that can orient us and orient our communities of faith when we try to discuss these issues as are coming up? I feel like there are some key questions that from a religious perspective we can ask. We must ask ourselves, do our deepest faith commitments encased in policy create any victims? So what do I mean by that? When, say, I'm going to stick to the Roman Catholic example. So consistent ethic of life, obviously against abortion. So if I were to vibrantly, fervently, so much so, labor for a reversing of Roe v. Wade. So I'm implementing my tradition's position, deep faith position as a policy. Would that create victims? Would it create victors? And who are those groups? So again, it's asking the social question of how my faith, when expressed politically and in policy making, who does it affect? Who does it benefit? Are there any groups that end up particularly vulnerable as a result of a policy that more closely resembles my faith commitments? So on this issue of physician-assisted dying, if I were to promote my churches, my traditions, viewpoint against physician-assisted dying, what vulnerable group would I be affecting negatively? What groups would I be affecting positively? Conversely, we must ask whether our deepest faith commitments, when enshrined in law, create favorable conditions for a privileged group. There are times when our religious commitments, when established in policy, would benefit particular groups. And what are those groups? What are the benefits? At what cost? For how long? Etc. Finally, when does faith plus politics, lobbying and legislating, interfere with our task to be prophetic or to stand as a contrast community? So if part of your religious tradition's self-definition is to have a prophetic stance before society, to be able to call out where society is victimizing particular groups, where society is deviating from a set of norms that now begins to erode the common good, what possibilities do we have of pointing out those places when we become legislators, religious legislators of policy? Does that in any way affect our position as prophetic voice or contrast community within society? Okay, so I'm trying to engage something which I'm getting into some trouble in my own tradition for mentioning, which is what I label political ethics of elective procedures. Political ethics of elective procedures, which means legalizing or enacting ballot question 2, or the legalization of abortion. All of these are elective procedures that a particular faith tradition can advocate for whatever conditions of life they see as being such that would prevent a person from having to elect them. So, in the question of abortion, in the Catholic Church, I can advocate strongly for creating the conditions such that no woman would ever feel that she is herself in a crisis pregnancy. And I could advocate it that way, so that it is as an elective procedure, not elective, right? The three perspectives that I'm envisioning here and that are coming together for me here are the moral ideal. Again, in my tradition, consistent ethic of life, that's the ideal. The ideal is that all life is sacred, all life has dignity, all life is protected, and that our policies reflect that, and that our policies sustain life in that way. However, what is politically possible? The moral ideal is not politically possible. So, is it possible to legislate charity, Christian love, love of neighbor? We have in the debates people having the conversation, or candidates having the conversation about how best to address those who most need material sustenance. Is the government the proper place for taking care of this? What is politically possible? Do we legislate morality? And then what is legally legitimate? Are there places where we're going to be contradicting our own legal and political positions in of the land if we try to establish the moral ideal as the law of the land? So those are three complicated elements that play out in the public square and that converse with each other and are often at odds with each other and very seldom, I think, in agreement with each other. And communities of faith need to be encouraged and empowered to have conversations relating as to what is it that we put in each of the spots and where is the meeting place and what does that meeting place mean for us as citizens, right? So we are participants in a religious community, but we also are political participants, and that's that meeting place in the middle. But unless we have those hard conversations at each of those, it's going to be hard to see what is, again, the ideal, the possible, and the legitimate. Okay, so can't find any other term except struggling with terms theologically and their policy implications. So I've mentioned a lot of things, especially with respect to my Christian background and understanding and grounding. What is dignity? How do we define that? So, you know, even just briefly in conversation with Terry, and he'll expand, the question of what is a dignified death? You know, for many people, death has no dignity. For Roman Catholics, and again, that's the Roman Catholic position and that of a number of Christians, not necessarily all Christian groups, is that death is part of a life lived with dignity. But in what way? How do we define it? In what way does technology and medical technologies enter into our conversation of what human dignity is, means, or could be? And in terms of how we understand ourselves, if this is part of your tradition, in concert, grounded by and with the divine. What is natural? You know, when we say from the moment of natural conception to the moment of natural death, well, what is natural? You know, is being shot by a robber a natural death? So what is, how do we define that term natural? What is vulnerability? So having 6 months to live, as this legislation points out, is a particular vulnerability, but how do we define it, and how do our traditions respond to human vulnerability? And particularly to the Roman Catholic tradition, a lot of questions have been raised about, is there a difference between human life and a human person? Within the Catholic tradition, there is no difference, such that an embryo at conception is considered a person, while for some ephesus, an embryo is human life, and therefore has a different moral category. And those, again, hard conversations that religious traditions need to have. And I'm close to being done. So what do communities of faith have to offer the public square in these discussions? I think a theological imagination, first and foremost, that entertains alternative positions and realities based on scripture, tradition, and experience. That does not mean that we're all going to agree on what each one of those things is telling us about a particular issue. Because if we look at scripture, we're going to look at them 5 people looking at the same scripture on the issue of that we're discussing tonight are going to come to 5 different conclusions, potentially. But at least we have that in our imaginary. It's part of the vision that we bring into the public square. And in most faiths, this imagination privileges the perspective of the most vulnerable of our society. So in Christianity, what we've labeled the preferential option for the poor, or the option for the poor and vulnerable. So our traditions invite us to think about these issues, asking first, not who am I or who are we with respect to this question, but who is suffering, and then being called to act from there. However, suffering is a word that goes on that list of terms, like what is suffering? Is suffer dignified? Are we romanticizing death in some way? And then we can have a lot more of that conversation later on tonight. But thank you. Those are just introductory comments and hopefully enabling us to have some conversation.
Thank you, MT. That's a lovely introduction for all of us in many ways, and certainly helpful to me. Although, perhaps coming out of a Jewish tradition, I can't speak with the same kind of clarity that maybe the church speaks with, although you did talk about, the 2 of us, about the importance of dissidence. We all know that the only one thing that 2 Jews can agree upon is what the 3rd person should give to charity. I think my remarks are going to take on a little different tenor because, Lisa, as you and I talked, I'd like to take you through a little bit of my journey in relationship to this particular topic. And where I stand here today as one of the signatories of this referendum has not come easily or swiftly. It's taken a lot of struggle for me. I've been interested in issues of death and of dying for over 40 years. My background is varied, as you probably heard, starting out in genetics, medicine, philosophy, ethics, psychology, and rabbinics. And like most of us, we come out of our context. So I think I look at this particular topic like I look at much of life from the vantage point of all of the blend of those particular disciplines that I spent my adult life studying, learning, and practicing. But I see this trend and this thread very important to me. I find it not simply in the document that you talked about, Lisa, from well, this was published in 2005, the task force by the Central Conference for American Rabbis was done in 2003, and I've evolved from there. But I started to recall my interest formally when I came to Newton in the early 1970s, and I was the only rabbi and one of 3 religious leaders in the town of Newton to create the first hospice in Massachusetts, which is the Hospice of the Good Shepherd. It's still around, it's active. I'm proud to be one of its founders. And that was not easy. It was hard to get people to think about this because, as many writers wrote, that there was a secret about talking about death and dying. That's changed a bit in our society, but not dealing with it in its real and practical and pragmatic areas as well. I also come to this question with many decades of experience holding hands of people who are dying, of counseling them in a synagogue setting, counseling them in a hospital setting, and of course working through it in therapy in my own private practice, to see the people's wrestling with the concept of death and how they should die is something that's actively going on at all times. The number of people whose hands I've held as they've taken their last breath is almost uncountable for me. So I come here with a passion and with an experience that's not simply academic. It's something that I've lived through. And in living through it, I've had to ask many questions, and I remember one experience that stood out as memorable in this arena, and it was early on in the AIDS epidemic, when a physician, at that time I created and formed, I was the ethics consult at Beth Israel Hospital, as it was known then, and I created the ethics program. And a physician came to me and said, I have a problem, and he came with tears and with pain. And he told me that a patient of his, who had been his patient for many, many years, had been diagnosed with AIDS and was not doing well. And the patient had asked him if he would help him to die. The physician was pained by this decision, but realized, and this goes back a number of years, that there was no context for this. We know that doctors have always used the concept that we know about as the principle of double effect, where they've helped people certainly be out of pain, but at a cost that was likely to take their last breath. And he knew that as well, but he was coming for other reason, because someone asked him to take an active role, not in doing something, but in prescribing medication. Recognizing the pain and the difficulty, the legalities, and the problems with this, I convened a meeting with the president of the hospital, the chief operating officer, with the legal counsel of the hospital, and the physician to discuss this matter. Our discussion lasted about an hour and a half. A pin could drop in between any one of our sentences because the air was so heavy. I'm not going to share with you the decision that was made, but the fact that someone was wrestling with this as a patient, and someone was wrestling with this as a physician, and a group representing an institution and someone representing the law were equally wrestling with it, told me that this is something that needs to be taken very, very seriously. I also remember holding the hand and listening to people cry out to me, those who were in the hospice of when we merged the Beth Israel Deaconess Medical Center. And there I spent a great deal of time in that hospice center. And people were comfortable. Hospice is wonderful. I'm a remarkable supporter of hospice care. But many of those people privately would say to me, I want to end this. I want to have the ability to end this. This is going on too long. It's a disservice to me and my family, although I'm grateful for the care and I'm out of pain. And at that time I began to wrestle with, well, what are the problems here? What are the stakeholders that are involved? What are the philosophical and theological underpinnings of responding to it? And I realized there are many stakeholders, but the two prominent stakeholders are the patient or the person and the physician. Each one has a different set of criteria for which they're responsible. Lisa talked about autonomy. In Jewish tradition, autonomy has not been the highest value. And I'm not convinced, I think personally, and she and I have had this discussion a couple of times, that the pendulum has been shifting from the late 1960s, early 70s, where the pendulum swung far to the opposite side of what was called parentalism now, or paternalism, to the autonomous side. I think that the pendulum's more swinging and moving. It's not in one place between those two. And so we have to take into account exactly what you were talking about, MT. The context is as important in many ways as a patient's autonomy. But the patient has to be considered autonomous. And here I looked at what's going on for the patients that I was holding in my hands, those who I was listening to. And I listened to two various dimensions we don't necessarily always distinguish. One was pain. Pain can be physical pain most often, and certainly in hospice, analgesia is possible, even to the point of principle of double effect. But there's also suffering. And suffering is not the same as pain. It's a psychic phenomenon. And what I've seen more than pain nowadays is not physical suffering, except with a few problems, and certainly even a few cancers that are very, very painful, is that people are feeling psychic pain. They are suffering. Different religious traditions feel differently about suffering. My opinion, actually, and it might be wrong, so you can correct me, those of you who come from different traditions, is that in Christianity, suffering has been sort of, in a way, elevated to something that's valuable and important in life. Clearly, suffering is part of life. There's the ebb and flow, and so is pain. It's built in. But Judaism has never elevated suffering to anything wonderful. It's understood that it's one of the things that we encounter in the course of our lives, and that suffering, in fact, is to be mitigated, not blessed. To be endured and try to be overcome, and not to treasure. There's no great honor in suffering. And I can say for all the people who have been suffering, I can say that's been the fact. We look at the physician, and what are the concerns for the physician? Well, as Lisa suggested, there are many codes that go back. Not many medical schools use the Hippocratic Oath anymore, because we see that even with looking at old documents, and this will go to a comment I have about Jewish law, just like they have evolved. In the code of, in the Hippocratic Oath, there's not simply a statement which says, neither give deadly drugs to people, but also never give a woman an abortive remedy. You can't have it both ways. If we're going to change one, we can change the other. They can evolve. And even the Code of Asaph, which is one of the early Jewish ethical codes for physicians, it says, take heed not to kill a person. And it goes through the same litany, actually, as the Hippocratic Oath. So physicians have values, but it led me to think about something that I've been wrestling with for years and which helped to flavor my attitude in the document of the task force, was the concept in Hebrew and in the Talmud of agency. And who is the physician the agent for? Is the physician an autonomous being? We all talk about the doctor-patient relationship. Certainly when I was growing up, and perhaps some of you, not only was it sacred, and I teach all my medical students that it's sacred, but the fact is that the doctor-patient relationship, and the doctor being the agent in some ways of medicine and the profession, is also the agent of the patient. But that's not true in 2012. Is the doctor his own autonomous being, responsible and agent only for himself and his understanding and his expertise or her expertise in medicine? Is the physician the agent of the patient? Is the physician the agent of his or her profession? The Massachusetts Medical Society is not approved and is not supportive of this model. Is the physician responsible and an agent of society? And I would suggest to you that one of the tensions of physicians nowadays is they don't know they are agents of all of these, and it's very troublesome. Jewish tradition has said that one should never do anything to assist someone who is dying. Your job is to make them comfortable, but you shouldn't be an agent, such as the Code of Asaph. But I look at people who are suffering, and I look at all of the advances that we have in medical sciences and practice today, which did not exist 1 year ago, let alone 10 years ago, let alone 50 years ago, let alone 2,000 years ago, as Jewish law was beginning to be evolved. And have to say that what we can do now is not what we could do before. We can prolong life in all sorts of ways, and that's inappropriate. I constantly teach my medical students, don't ask patients, what would you like us to do so that would you like us to do everything? Nobody knows here what everything looks like. I can tell you, it's ugly. So a physician's job has a particular responsibility to care for his patient or her patient. Not necessarily to cure, but what's happened is that palliative care has become a legitimate model of medicine today to help people be comfortable and accept what is inevitable. And to use this actually in medical decision making. It becomes as well a part of the decision-making model. And if that's the case, when we know that people are about to die, none of the people who we're talking about for this particular proposed legislation and referendum want to die. They all want to live. But they also know that they cannot. And so what this legislation does is it provides for both the physician and for the patient an autonomous capacity to make a decision. Lisa knows I forgot to mention the fact that not only is this a voluntary choice by people, by patients, it's a voluntary choice for physicians too. They do not have to do this if one of their patients asks them to. They can be a conscientious objector, a dissenter, if you want, not to do this practice. Although, like other areas of medicine, they do have a responsibility then to move this question along to a colleague who will accept the responsibility for assisting in this fashion to assist a patient. It's for that reason now that I have actually lumped this whole project, and the reason that I joined, and I talked to one of the people who is on this 10-person signatory group, and said, you know, the only category that I can look at is this is just one extra extension of palliative care, of making people comfortable and getting them what they want, not administering. Doctors administrate all sorts of medications that can actually kill you if you take it the wrong way. This is helping them. So that's why I'm arguing for this, and I do come with a bias, because I think as a rabbi, our job is to provide caring, healing, and support, and honor our patients. We're honoring them by listening to them and helping them relieve their suffering. Thank you.
So I'm just going to ask all of our panelists to come up to the podium here. And we have a microphone for people in the audience to ask questions, and maybe I'll just begin by asking a few questions of just clarification for both MT and Rabbi Bard. And maybe Rabbi Bard, just since you just spoke, I'll start with you. I just want to make sure that I understand your position, because I think part of our goal tonight is really to ensure that you people in the audience really come away with a clear understanding of what the different religious perspectives are on this issue. And I think it's important to note that there are a variety of religious perspectives, both within Judaism and within Christianity. So you made a statement, Rabbi Bard, that Judaism does not support, I don't recall the exact language, but to support assisted dying, but at the same time, we don't elevate suffering. And from your perspective, despite that emphasis on not supporting assisted dying, because of your experience as a pastor and as a rabbi and working in hospitals and hospice, your concern for suffering has transformed your perspective from even, I should say, the task force that you were on in early 2000, which the Reform Task Force on this issue, which came out very eloquently, I would say, in opposition to assisted dying. You've evolved to being in favor of it. And so what I'm trying to understand is if you can root that for us within the Jewish tradition a little bit more deeply. And would you say that that is reflective of a broader perspective within the Jewish tradition, or is this really just a personal perspective and not consistent with the Jewish tradition?
I'm glad you used the word Jewish tradition, because when people have asked me, what does Judaism say about anything, I'm always reluctant, because as the anecdote that I gave at the beginning of the joke, it doesn't have one voice. If we read the Talmud, there's always an on the other hand. But having said that, I think there are certain value systems that do inhere in our tradition. Caring for other human beings. There's a statement that one cannot move into a town unless there's a physician there from a Jewish perspective. The fact that caring for those who are ill or the dying is one of the highest values in Jewish tradition, I think understands and underscores the fact that not only is the passing of life a significant event, and certainly a cosmic event. Every life is as if the whole world depends on it. But providing care for the family, the context, as well as the patient, is a sine qua non. And so one would make their choices, and certainly you're not going to get agreement on this particular ballot issue within Jewish tradition, but to make a variation of statement of saying this is important and seminal, perhaps, particularly given the light of contemporary medical intervention possibilities, I think is gaining more and more and more support. And I remember being on a panel going back 20 years ago with a person of an Orthodox persuasion who said to me privately that he supported exactly what I was saying, which was somewhat similar, not the same, at that time, even though his tradition didn't and he couldn't say it publicly. So that's the best I can give you.
I mean, I think that the challenge is that I think you're absolutely correct that Judaism places a significant emphasis on relieving suffering and caring for people at the end of life. But there's a big difference between that kind of statement and that value and saying that it's okay for us to legalize or encourage or make it an easy option for individuals to choose to die when they decide that they've had too much. And so there's no, I don't think anybody's disputing the idea that Judaism cares about suffering and relieving suffering, and I think we should be very privileged or recognize how blessed we are to live in the year 2012, where we have excellent pain medication and the ability to control physical pain. And one of the real challenges here, I think, is what does Judaism have to say about existential suffering? And is existential suffering a good enough reason to justify assisted dying?
Well, let me also say that this is not a quick, easy resolution. And I think that the steps that you pointed out make it not easy. And clearly the safeguards of being concerned about a person's mental capacity has been preeminent in Jewish tradition and Jewish law throughout its inception, so that we know that people who are found to be mentally challenged in one way or another, even if it's in a temporary way, are to be treated differently than people who have full capacity, full cognitive capacity. So I think from that perspective alone, we have to understand that this is not an easy out. And the safeguards that are putting there are putting the onus on the individual. Now, will the Jewish, I say this with a tongue-in-cheek, will the Jewish perspective on the concept of someone who takes something that will ultimately be that which terminates their life evolve? I don't know. In Jewish tradition, we find that someone who does that is regarded as, provided they're mentally competent, they are to be michutz l'machaneh, buried outside of the burial site. They're to be buried within the burial site if they're mentally incapacitated or there's some other structure. It may mean that there's some evolution that needs to take place there as well. And I think that our traditions and our religions need to evolve just because something was written a long time ago and become a tradition, it has to in some way accommodate as well for what is contemporarily possible.
Right, so that's one perspective, and then the question is that still, can that still be identified as a Jewish perspective, and how closely does it have to be connected to that tradition and rooted in those texts, those historical texts? I want to just turn to MT for a moment and ask you, MT, you mentioned that from a Christian perspective that all life is sacred, but you also began by talking about dissenters. And I'm just curious, can you share with us a little bit more about, is there a spectrum there within Christianity in terms of the attitudes towards this? And is it really as simple almost as you make it sound that all life is sacred and therefore there's no option here, because no matter what the person's quality of life, or no matter how much pain, whether physical or existential, a person has, that sacredness of life would not justify assisted dying?
Yes and no. Next question. Okay, so there is a spectrum of within the all life is sacred camp. So all life is sacred, including for some who are environmentalists, all non-human life as well. So the question is, what is the moral demand? What legitimate moral demands does that statement make of a society and the care that that society gives the members for which it is responsible? So that's where the rubber meets the road of saying that blanket statement. And so you have something, and then we have this messy thing called sin. And then what are moral provisions that we make for saying all life is sacred, however society is messy and removed from God because of sin, or somewhat removed from God. And some would say absolutely, some would say only in image, some would say in very different ways. So yet another spectrum of interpretation of how removed society is from God or God's ideal or God's plan. So you have something like the just war tradition, where the taking of life in a case of a war, of a justified war, goes through all these sets of moral gymnastics to be able to determine that it is at least not necessarily sinful and potentially just to take the life of the enemy. Right? So does that mean that we've stopped believing that all life is sacred? No. Terry mentioned the principle of double effect, which has been used in some Christian arguments for abortion or procedures to protect the health of the mother that also may result in an abortion, which is how it's being used in medical ethics, Christian medical ethics. So there are a spectrum of interpretation, again, of what all life is sacred, what moral demands that makes of society. A body like the Roman Catholic Church explains that when it comes to issues of life, it wants to err on the side of caution, especially with respect to things such as consciousness, personhood, autonomy, and dignity, freedom, quality of life. Because A, it sees a person's life as intimately interdependent to its social context and its familial context, such that dying well is seen as maybe a person suffering greatly, but who dies with the support of their children or in some way, shape, or form, intimately linked with someone else who is caring for them. So that is considered something, maybe a theological romanticization of suffering, an exaltation of suffering to the point where it says, well, suffering in society is not just the individual person, but it's about how that community grows through, develops through, morally does stepping stones or milestones by carrying someone through their suffering in their final days. So there's all that discussion there. So the Catholic Church wants to err in the side of caution and say, while medical technologies are providing us with very advanced ways of either reproducing or terminating the life of the unborn, especially in situations with serious disabilities or cases of rape and incest, etc., really passionate cases, and critical cases, the church will say, we really do not have the full knowledge of what is going on with that life. Person with the church would determine, others would just call it human life, in order to make a decision such as taking that life or terminating that life or assisting in the dying of that life, because we don't have the full knowledge. That full knowledge is only in God, and therefore, and it's the same for saying being all life is sacred, applying to cases of the death penalty and being against the death penalty.
Okay, great. So let's, I want to open it up to questions from the audience, and maybe people can raise their hand. We have a microphone to give you so that everybody can hear the question. And maybe while people are waiting, I wanted this concept of double effect has been mentioned a couple times, so maybe I'll just take a moment to explain that concept for people. It's a complicated concept that's really rooted in the Catholic tradition. It's embraced in medicine in many circumstances, as MT mentioned, but it's the idea that an act can have two consequences. One which may be foreseen, and both of which are foreseen, but one which is intended and one which is unintended. And in the context of end-of-life care, it's used as a basis for justifying administering increasing doses of pain medication to patients, even where those high doses of pain medication may actually result in the suppression of respiration and the death of the patient. The intention is actually to relieve the suffering. So the act of administering morphine has two consequences. That's the double effect part of it. And it's considered to be ethically justified because the intention is to relieve suffering, not to cause death. But so it's a complicated
tradition. That is also true in the principle of kavanah, or intention, is always seminal in many of these decisions.
Right, great. So let's open it up. There was a question in the front.
Question for you. And even though this panel is about the religious perspectives, when you looked at the Oregon figures, you said that part of the story was not represented there, and you seem to know what that was, and could you share that with us?
Okay, so I hope everybody heard the question. It's what are some of the limitations in the Oregon data. I think that it's a good question, and there are limitations, I think, in terms of what is actually being reported to the state and what we're really getting data on, in part because of the way the law is structured, such that no physician or healthcare provider has to be present when this occurs. When a patient takes the medication. So we don't really have good data on what's happening when a patient takes the medication. We don't really have data on who's administering the medicine, even though in theory it's supposed to be self-administered. We don't really know how the legalization of this possibility affects people's thinking who have a terminal illness. In terms of whether they feel increased pressure, if you're living in a state where this is legal, do you feel increased pressure to choose that as an option? Because people are not, there isn't an obligation to discuss this with family, even though in Oregon we did see that the majority of people actually did tell family. Frequently people think that they're going to be a burden, but they never articulate that or bring up that issue and have a conversation with family about it. And if they did discuss it with family, they might hear the family had a very different perspective, and as MT suggested, that they may view this as an opportunity for their own growth and development and through caring for someone with a terminal illness. So I think that there's a lot of questions that we really don't know the answer to in terms of what's really happening at the end of life with this medication when people are taking it and choosing it. Other questions? In the back. Michael.
Are there any differences between this proposition as it's constructed currently and the Oregon law? And if there are, what are they?
insignificant. They're really minor. I can't even remember. I actually have gone through both of them, and they're almost no.
I think there's one difference in terms of the tracking of the medications, that we have a very sophisticated system here in Massachusetts, and so the dispensing of the medications and whether they're used or not might be helpful in tracking, but that time will only tell that.
So that's not necessarily related to the law, though. That you're saying
It's
that's the way Massachusetts practices the dispensing of controlled substances.
That's right.
There are a lot of questions that are raised. This is a related issue in terms of what happens to unused medications and what happens to medications that are during the time period where they're not being used and patients are keeping them at home and other people have access to them, and concerns have been raised about that. But I think that there's similarities on, there really are not significant differences between these two legislations. Jonathan, back. And then, Josh, if you want to give it to Mickey Caleb in the front, he's got a question after Jonathan.
I get the impression that from a religious perspective, when you have a medication that has a double effect, that's more palatable from at least some people's point of view. So I was wondering which medications in particular are envisioned to be used in this legislation. I mean, are there medications that can be construed as having a double effect as to relieving suffering in addition to events and the death?
So it's not just the particular, it's usually barbiturates. The law actually does not proscribe what medication needs to be used. And that's something that physicians determine. In Oregon, there's usually 2 different barbiturates that are used. But they're in such high doses. They're oral pills. You have to take about 90 to 100 of the pills in order for it to be effective in ending your life. So I think it's hard, it's really pretty hard to make an argument that your intention is to relieve suffering in that case versus your intention is to die. And the reason why the argument of double effect works in other end-of-life care settings, and also even in the hospice setting or in an inpatient hospital setting, is because typically we're talking about intravenous doses of medication like morphine, where, as you know, Jonathan, we're titrating, we're gradually increasing the medication to the desired effect. And the desired effect in those cases is relief of suffering and pain control. It may have the consequence of suppressing respiration and death as a result of that respiratory suppression, but what you're focusing on is titrating the medication up to the point of controlling pain and suffering. Mickey?
Yeah, I have a certain question that someone is very sick. You may not qualify for getting help.
From this legislation or from medical care or doctors?
In any case, there is no medicine that's going to help that person. The person is suffering horribly. And I've seen a situation like this myself. And being with that person makes me very unhappy for him because his existence isn't real.
So, Mickey, you're raising a really good question about suffering at the end of life, and my concern about the situation that you're describing is that individual has not had access to good palliative care. So palliative medicine is an area of medicine that is relatively new, I would say, within the past 10 or 15 years. It's actually only become a board-certified specialty within at least the past 10 years. And people are not aware of the existence of palliative medicine and the fact that that kind of suffering that you're describing doesn't have to happen. So I think that part of our job here is to ensure that people who have a terminal illness, who are suffering, are aware of their options. And the legislation actually makes some effort to ensure that that occurs. But we, as a community, I think, need to do a better job of educating people about those options and making sure that they're not suffering. Because there's no reason why someone who has no therapeutic options in terms of medication should have to suffer in the way that you're describing.
And we're a little late in some of this here in New England. We're a little bit late in this process in New England, even though I said, you know, I was one of the earlier formers of the hospice and Good Shepherd, because I had actually the good fortune for my parents when things were going downhill in the Midwest. And before there was any knowledge of these two people getting to their last 6 months of life, there was a hospice setting, which was for the whole community, which 2 years before began to take them under their wing. And so they were actually serving the community of people who were working toward the end of their lives, but no necessary diagnosis of the fact of a limitation that has been put on them, so that they would get the kind of care that they need. We have not done that to the extent that we ought to be doing here in New England, and I hope that we ultimately do.
So just a couple of questions over here. We'll take one or two more questions, given the time, then we can have some conversation afterwards.
I guess this relates to what you're talking about with palliative care, but one of the things that struck me in the statistics on Oregon was how many people were in hospice care, where hopefully they were also having a period when they were discussing palliative options. And could you help understand that? Because up until you shared that data, I was thinking, you know, one of my concerns is that we're not having enough hospice care when we don't have enough palliative care here. But then you have that data there, so I'm curious how you understand that.
So are you asking why, if in fact 90%, almost 90% of people in Oregon were in hospice, why did 63% still feel that they needed to use this medication? So my interpretation of that is that this is not about pain and suffering, right? I think that that's an important fact to recognize, and I think the data that we have from physicians in Oregon about what are the end-of-life concerns that I shared with you, where loss of autonomy was a concern for about 91% of individuals, suggests that that's really what's going on. It's about wanting to control the timing of your death. It's about not wanting to lose control over your bodily functions. It's about your quality of life. So it's not about physical pain and suffering, but it's about a desire to not be a burden on family members and a desire to have more control and more autonomy.
I think it's also part of palliative care, because we're talking about goals, individual goals, so that's, I'm kind of just wondering about that. I wasn't just thinking about physical pain, because I know hospice and palliative care addresses the whole being.
It's existential pain, and the autonomy, the ability, if we think about it as individuals, we learn to walk, to talk, we're always gaining things. And the more we're confined and unable to do what we normally do, you're taking away car keys from people is very, very difficult. And so people feel psychologically empowered, and we find that that's very important. Many people who are given prescriptions actually do not act on it, and that's what Lisa was talking about. It was the feeling that they could be in somewhat of a control of their own destiny that's important. And this is an important feature that you're raising, because if you notice, the hospice community has not supported this proposed legislation.
And if I could just add real quickly to that, in terms of the Christian perspective of that point, that loss of autonomy, loss of existential autonomy, is something that is highly regarded within Christianity. Or not an absolute loss of existential autonomy, but that in fact is in some way something that brings one in greater communication with God and the divine, so that in fact it is not something that people look forward to. I don't think, like you said, no one looks forward to dying, I don't think. But it is something that theologically is understood as part of the dying process, that loss of autonomy, while being a quality of life question within Christianity, it is included in dying well.
Okay, there's a question in the back.
My question relates to incarcerated persons. How and to what degree does this affect persons that are incarcerated in the state of Mass or elsewhere?
That's a great question. I don't know the entire answer to that question with certainty, but I would suspect that an incarcerated person has access to medical care within the context of a prison. And part of the question there is whether or not the prison physicians would be willing to engage in this or support this. And if, given, as Carrie mentioned absolutely correctly, this is completely voluntary for physicians, for pharmacists, for healthcare institutions. So nobody has to, if this law passes, nobody has to participate in it, including whatever physicians may be in the prison. But I think that there becomes if that local prison physician is reluctant to prescribe a medication for a patient within the prison, then it would seem to me the state would have an obligation to connect that patient with some other healthcare provider who is willing to meet their healthcare desires and needs. We have a general principle of justice within our society, and certainly when it comes to healthcare, we believe that everybody should have equal access to healthcare, even though we clearly fall short of that. But that's the ideal, and I think that we would certainly make an argument that people who are incarcerated should have equal access to this, assuming that they meet the eligibility criteria, and we want to be sure that depression in that circumstance was not driving and motivating their request. Okay.
The question about control and autonomy raises questions for me about what this asks of us as distinctly religious people who speak certain things about the God that we understand and what sort of agency we think we have in our life in relation to that. Specifically, Professor Davila, I'd love to hear you say more about what a Christian witness to dying well is. We, as Christians, we look to the life, death, and resurrection of Christ, and we know the ways that pointing to that suffering has been used to oppress. But also, we say that there is a distinctive Christian witness in death. I'm curious to hear about the distinctly Christian and Jewish witnesses about how we die.
Yeah, and also because when you get to, again, to some social justice questions in terms of end-of-life care and responsibility and moral obligations, so much, to be frank, falls on women. So much of the physical burden of care at the end of life falls on women of various generations, and it's simply part of how our society has been constructed. So I don't want to romanticize or idealize, or speak about the moral or the theological ideal of a Christian dying well and loss of autonomy within the context of suffering in God, without recognizing that there's a serious price that is paid by those who care and those around, and often some very life-changing prices to pay. And so part of Christian witness in terms of a tradition, I'm concerned about the pastoral implications of the pastoral question, and I wish Brita Gil-Ostern in this conversation. The pastoral care question of how a community of faith carries a family through this decision-making. Until very recently, these weren't even courses in Christian seminaries, about how to carry a family or accompany a family through the process of a dying family member. But now there is more of that. So again, I think there's a huge pastoral catching up that churches need to do in order to try to practically implement this theological ideal, or at least practically try to apply the theological ideal to concrete situations. And then see if that theological ideal needs to evolve based on some of what we're learning about the process of dying, or the process of autonomy, or the process of cognition and volition. So it's a place where science, technology, medicine, and theology have not spoken to each other for a long time, and with reference to pastoral care. And what you were saying, at least what it suggests to me is that there is a lot of catching up to do. There's a lot that has been done, but there's a lot of catching up as well.
In Jewish tradition, one is not supposed to die alone. And I think that speaks to whether it's pastoral care by someone who's an official in that role or someone who is just participatory in it. It understands that continuity and context are always part of the human reality. And so I think while we don't have a language of a good death or dying well, dying appropriately, which leads to the dignity of the human being, means that one doesn't do it alone. And it's sort of built into the system. And so, in fact, when someone dies, they are also they're not to be alone until burial. They're to be accompanied. And so it talks about a journey that one sort of continues even after death, at least in this fashion, and that the family knows this, and the family becomes part of that mourning process as soon as possible. So if we want to call that theology, we can certainly put it into that language, but I think it's always based on human reality to that.
Okay, great. We're going to take one last question.
It's not really a question. I feel the need to comment on the Christian perspective from a Protestant point of view. I am a UCC pastor. You know, I think, well, I'll speak for myself, but I think that a number of my colleagues would probably agree with me. We certainly believe in the uniqueness, individuality, and dignity of human life and human beings. But we do not exalt suffering. We believe that Jesus suffered on the cross for us and suffered in part to make the world a better place for all human beings, for justice and dignity for all people, and certainly for what he referred to as the least of these. And so it's up to us to continue in that process and do that work. We also believe that, I think more so perhaps than Catholics, although I'm not sure, that God is around us, within us, in some way, spirit, ruach, breath, whatever. And so is very imminent and very with us, very much with us. Now, I won't say that all Protestants believe that, and some Protestants are at different stages in their beliefs. But I think it also depends on what your overall understanding of God is, who God is to you individually, makes a great difference. And so when you talk about autonomy, it's more, I think, between the person and God, and not so much, you know, whatever is legislated or what other people think. I have sat with, as all clergy, I'm sure, I hope have, you know, with many, many dying people. And, you know, I agree with Dr. Bard that, yes, it's good to have somebody there. It's good to be able to help people to tie up loose ends before they die, if that's possible, whether it's with family or friends or with God. So I think that's perhaps a little bit of a different perspective. I don't know, but I just felt I had to say that.
Great. Well, thank you so much. I want to thank all of you for your comments and questions, and especially thanks to MT and Carrie Bard for sharing with us your different faith traditions, perspectives. I think we're all enriched by hearing about each other's traditions And my hope is that all of us are in a better place in terms of understanding the complexity of this issue and formulating our own opinions so that when we go to to vote on November 6th, we'll have a better perspective on where we come down on this issue. So thank you very much.